is a senior medical physicist at the Prostate Cancer Agency.
Good evening, thanks. It's a pleasure to be here. Really excited about today. I hope you're in the mood for some math, maybe a bit of physics and statistics, and we're going to keep it light. So I hope you enjoy the ride. So here's something that I hope to cover tonight, a bit of an overview. I'm going to try to describe the problem, one of many problems in prostate cancer. Talk a little bit about what we do, and then what we can do. Then we'll talk a little bit about the project that we have, which is this whole concept of personalizing safety margins for radiation therapy cancer patients. We'll describe some of our aims and where we're at, discuss really briefly some of the challenges and some of the successes, and then one or two slides for some quick comments. So here's the problem. You're probably familiar with seeing the slides on the website, that we're looking at 1 in 8 cancer men will be diagnosed with prostate cancer, and that's roughly about 24,000 people. And so this is a very significant problem in Canada. The typical process, what happens after you get diagnosed, is that you will get sort of pigeonholed into one of the stages, right? So Bob has a particular diagnosis, and so based on his clinical symptoms, he'll get staged in stage 1, 2, early, intermediate, high risk, and so forth. And for each one of these different kinds of stages, there are a variety of treatment options available for Bob. And the thing that I really just wanted to mention here is that radiation therapy is often used for treatment in many of the different stages that cancer patients across the family, prostate cancer receive. So radiation is quite a prevalent mode of treatment for many men that get prostate cancer. So here's just another sort of slide that basically shows, but the bottom line here is that you're looking at around 25 to 40% of those diagnosed with prostate cancer get some kind of radiation therapy. How are we doing with this, in the broad scheme of things? Well, here's some statistics that are pulled from the cancer website, cancer.ca, which seems to suggest things are doing pretty well in terms of controlling disease after 5 years. So there's a bit of a good story there. But one of the things that's not really captured in this table is the fact that there's a fair number of complications that a lot of patients get when they receive the radiation. What are those side effects? We can go into detail what these kinds of side effects are, but you might be familiar with some of them already. But we're talking in the short term, over the course of the treatment and maybe a few weeks after, fatigue, decreased energy, weight loss. And then it can be a little more serious. You can have issues like blood in the urine, frequent urination, and so forth. There could be some long-term effects as well, things like scarring tissue in the urinary passageways, rectal dysfunction, and blood in the urine and rectal bleeding. These things can be significant problems for a lot of patients that receive radiation therapy. Well, what does radiation therapy look like? So what I want to do is just basically kind of visually step through the process of what does that mean. One of the things that happens during radiation therapy is that we create kind of like a digital image of a patient when they get the radiation therapy. So many of you might be familiar with CT scans. We collect the CT scan to kind of give us a snapshot of where the different organs are. The bladder, the rectum, the prostate, seminal vesicles, all these things relative to each other, so that when we try to put radiation beams on, we can model the radiation very accurately. And so typically you might be looking at something like 5 beams that are directed right through the patient, intersecting such that the prostate is receiving a very high amount of radiation, and the rest of the tissue is not getting as much. And so if I were to take some slices, if I were to take that CT image, it's kind of like a loaf of bread. If I were to take one of those loaves up and look at a cross-section through the prostate, what you can see is that the radiation distribution is designed to conform around the prostate or the target itself. And the goal here is to try to make sure the radiation covers the entire target and not anything else. Here are 3 different views of that. So here's a sort of a transaxle plane playing this way, and on the bottom is a plane going this way, and on the side here is a plane that goes sort of in this direction. And if I were to just do a little color wash of where the high amount of radiation dose is, I would just show it right here. So this is kind of where I'm delivering most of the radiation around the prostate, and I'm trying to minimize the radiation dose around the prostate. So here's looking a little bit closer into that treatment plan design for this particular patient. And what you'll see here is that for all the patients that get cancer treatment, get radiation therapy, we have in cyan here the actual prostate plus any other diseased tissue that we're treating. And so you see that we're covering a very nice high dose around the prostate itself. So the target is nicely covered. But we find that it's not just good enough to irradiate just the target. What we have to do is irradiate a margin around that target. And the reason for this is that this image that we have with the patient only represents one day that the patient came in for their CT scan. In reality, this patient might be coming in for 5 weeks, might be coming for 7 weeks. And every single day, the prostate is going to be in a slightly different spot. And so in order to account for all of those positional variations in the prostate as the patient gets their treatment, what we have to do is to apply a safety margin around the actual target itself. And so this margin is kind of like a safety margin that we have to put around the target. The size of that safety margin is typically on the order of about 4 millimeters to 10 millimeters. And that's actually quite small when you think about it, right? I mean, it's like the size of your pinky, or maybe half the size of your pinky. But that's how accurate we really need to be in order to make sure that we don't give a lot of complications to tissues around the prostate. If you take a look at that safety margin that's needed around the target itself, what you find is that, unfortunately, we have to irradiate some parts of the normal tissue. So here, for example, we see that you have to irradiate a little bit of the rectum. And here on the top, we find that we have to irradiate a little bit of the bladder. And so this is where the side effects from radiation come in. The amount of volume and the amount of dose received to those normal tissues is directly related to the kind of complications that these patients get. So, going back to the safety margin, is the size of the safety margin important? Well, there's a lot of data to suggest that indeed it is. And that the side effects increase as the volume of normal tissue and the radiation dose that it receives is big. So the bigger that gets, the more chances there's going to be some complications. We also know that the opposite is true, that the more you can reduce the amount of healthy tissue irradiated, the less likely they are to have these side effects. And this is possible today with using very novel technologies like being able to image to where the prostate is in every single treatment that allows us to find ways to shrink the amount of that safety margin. How do we go about determining what is the appropriate safety margin for our cancer patients? Now, this is kind of where things get very sort of statistical. What we do is we look at a ton of patients. We'll look at, say 100 patients. And what we do is we'll try to actually measure how much that prostate moves. And then based on those 100 patients, we take an average and we do some statistics on how much things move. And then we use that average or the standard deviation, whatever those statistics are, to help generate a safety margin which we think is safe for a large population. So if you think about it, what we're doing is we're kind of saying, like, everybody in this room, we're going to give you the same margin if you have a certain stage of disease and get a particular kind of treatment. And that's okay. That's what we've been doing for a really long time. So here's just the process that kind of illustrates that. So each patient, you have 1, 2, 3, 4 patients, and we calculate averages of those motions, and we put it through a meat grinder statistics, and then we spit out a volume and we say, here's the margin we're going to use for all of our patients. It worked pretty well. But one of the things that we contend is that you don't know what you don't know. And there could be other things that determine what the size of motion is for an individual. For example, if we know that a patient has a lot of problems with gas, the prostate might be moving a lot more during their treatment. It kind of makes a bit of sense, right? I mean, if the patient has a lot of gas and they're coming in for treatments and they're suffering from a lot of gas during their treatment, then the chances of the prostate moving during the treatment are pretty high. Why don't you record that kind of information to help us decide how big that safety margin is? So that's one of the things that we're thinking about. There's also some data to suggest that BMI index might be a measure of how much the prostate moves. So there's all sorts of little hints in the data that say that maybe there's other little factors that determine how much things move. There could be a variety of different physiological factors that could play a role in how much a patient's prostate moves during the course of treatment. So that's kind of the fundamental research question that we put ourselves. We asked ourselves, well, can we and should we personalize that margin around the prostate for low and intermediate risk prostate cancer patients who receive radiation therapy? Should we do it? Does it make sense to do that? And so for me, it's not should we, it's how might we. So that's the question that we're looking at in this research. Is we're asking the question, can we do this and how can we do this? So the basic approach that I described earlier about populations is shown above here. But what I want to do instead is I want to say that Bob, who has prostate cancer, might have a variety of different things going on with him. He might have a specific BMI, he might have a specific PSA score, Gleason score, he might have a particular volume in his prostate, he might have problems with rectal distension, he might have problems setting up on the treatment unit. What I want to see is to see if I can collect all that information for one individual and put that in a large database. And then see if I can collect patients that have a similar profile and see how much those prostates, how much motion occurs within those patients. So what we're kind of doing here is that we're taking an individual patient, we're looking at how much motion is occurring for that person, and then comparing them against someone else that has potentially a variety of different personal factors, and seeing if they move the same or if they move more, or even less. And by doing so, it might be possible for us to be able to discern whether someone who has a particular very high BMI or a very low PSA score, whatever it might be, maybe we can give them a smaller margin, and therefore, maybe we can reduce the chance that they will get a complication. So one of the things, so we have a variety of steps in order to try to see how we might be able to do this. So some of the things that we're doing is that we have to go through and get data. Right? So there's a big process that we're involved in terms of auditing, and collecting data, and actually doing some analysis. One of the most important things in all of this data that we're finding is that it's really important, the most important factor that determines that size of the safety margin is how much motion occurs during the treatment itself. Now, for many of you that might have received radiation therapy, you might remember that when you go on the couch and lie down and get your treatment, you might be on the couch for like, say, 2 minutes, or 3 or 5 minutes, somewhere in that space. And within that time, the position of the prostate can be moving all over the place. And so what we're finding is that kind of information, we'd like to be able to capture how much motion is occurring during the treatment itself. After we get that kind of information, we can collect all sorts of other information about the patient. And then we can try and see if we can put that in a potential database. One of the things that we're doing right now is we're trying to actually measure this motion. So one way that we can actually better or more accurately target the tumor is to put small little gold seeds inside the prostate for their treatments. The gold seeds show up really nicely on an X-ray image. And by taking an X-ray image just before their treatment, what we can do are very small to fine adjustments of the patient and align them a little better to the radiation beams. And so this is a common procedure that we perform, putting these small seeds inside the patient that help us better target where the tumor is. And so one of the things we're doing is we're taking images before their treatment and after their treatment and seeing whether those seeds move around. So here's an image of, just basically 2 images of a patient with those seeds. So here's an image on this side that shows an image that goes this way, so you can see the pelvic bones. And the image over on this side shows a lateral image, so you can see sort of the hip here, the hip bones. And that's where the seeds are, that's where the prostate is. And so here's a picture of the patient's seeds just before they got their treatment. And I'm just going to toggle back and forth, and I tried to align this as best as I could. But you can see that just after the treatment, the seeds have shifted, right? It hasn't shifted a lot, but it's significant enough for it to actually make a difference. And so just toggling this back and forth again, it's not perfectly aligned, but when you actually go and measure the distance that those seeds migrated during the treatment, it's on the order of about 3 millimeters. And that might not seem like very much, pretty small amount. But remember, that safety margin was only about 10 millimeters. And so that's roughly 30%. Right? And if I were to track that amount of motion that's occurring every single day and plot them on a graph, I would get something that looks like this. So the red shows motion that occurs in the vertical direction, and the brown here shows the motion that occurs up and down, and the green shows the motion that occurs left to right. And you can see they kind of bounce around 0, but sometimes they kind of trend, right? So maybe for this particular gentleman, he's kind of trending, minus 5 millimeters every day, and then kind of migrates back up again. So maybe this in particular individual doesn't need a very big margin vertically, but maybe he needs a bigger margin longitudinally, like this way. And that's the kind of information that we're hoping to try to discern. Other things we're doing is, with this particular research is to explore that relationship between motion and those patient-specific factors. And so what we have to do here is we have to use a sort of like a heavy-hand statistics in order to see if there are trends and patterns. And so we have a master's student in medical physics that's developing some software to do some of this work. And so he's using some clever little programs that you can get for free on the internet, one called Pandas and one called Sidekick. And here's a word I just learned the other day, data munging. Do you know what data munging means? Apparently, you know what it means? It's kind of like, you know how you have a table of data and you might have like 1 or 2 pieces that are missing, and then you go, I can't use this, God, doesn't have enough data in it. Well, data munging is kind of like doing a little bit of jiggling around with the data in order to make it into a nice form that can be thrown into a supercomputer. So the supercomputer doesn't blow up and give you nonsensical results. But it's basically kind of making the data ready for you to do some big-time analysis. So these are some of the things that we're using. Some of these tools are pretty cool because, like the Sidekick, for example, it's the same kind of software people use for financial analysis. So people that make the really big bucks working on Wall Street and stuff are using the same software to look at trends in the stock market and so forth. And so the third part of the project is to try to build a tool that helps us predict what the size of the safety margin is. And so, the end goal here is that we have a patient, Bob, who comes in and he says, hi, my name is Bob, I got a PFE score of this, and my prostate volume's roughly this big, and so forth. And then, of course, Fred comes in and he has slightly different characteristics. But then with Bob, what we can do is we can put all that information into this machine learning system, and it can spit out, based on the history of patients that have a similar profile, what's the best margin for them. So here you have a supercomputer, which is turning out an answer saying, "Hi Bob, to reduce the chances of side effects, assuming you behave like other patients that have a similar profile, we think your margin should be 5 millimeters." And so just to visually represent that, here's Bob's radiated volume that we would use for treatment. And then using that information, Bob's information, we can collect the motion that's occurring every day for Bob and put that back into that machine learning system to help it make it smarter. So that when Fred comes, we've got some better data to use to predict what kind of margin he might need. And so we might find what's Fred's radiated margin might be slightly different. So that's kind of the goal. So some of the successes of this project so far, it's pretty early days so far. What we're finding is that there's a very large provincial effort to look at prospective outcomes. It's one of the largest databases that we're going to have in the world here in BC. And so we think that this data is going to emerge very easily within the scope of that project. We're pretty excited about that. The other really cool thing about this project is very multidisciplinary. We have physicians, we have technologists, we have people like me, we have students. And so anytime you have sort of a mixture of individuals, you generally can have an environment where you can bring out some good and clever ideas. And the other really thing I need to mention is that anytime I kind of mention this to other people, I say, yeah, I've got this grant, it's really cool. People get really excited about it because it's kind of hitting on things that we know that are out there today. Some of the challenges that we have, the classical ones are garbage in and garbage out, right? So we have to be really careful about how we put that information in and what kind of data we use for this algorithm. And the other thing that we realize is that we don't have, you might have heard in the news the whole issue of big data. What does big data mean, right? Like millions and millions and millions of bits of information that are supposed to be used to help you make your life better when you plug it through IBM's supercomputer. But we don't really have big data. What we have is very rich data. We have data that for one patient, but there's a ton of information for that one patient. And so the trick here is to try to figure out how to process and use, how to analyze that. Some final comments. The whole notion of individualized patient care is upon us now. And so we know just recently press releases abound of millions of dollars going into the BC Cancer Agency, the research foundation, for finding ways to individualize the way we deliver our treatments. So this is a very common theme. What we're doing is we're saying that everybody's not vanilla flavored anymore, and that we can do better than that. And we also know that the whole notion of big data and analytics is going to be more and more important in today's society. And what we're hoping to do is to be able to sort of capitalize on that interest and be able to use those tools that are available for us. Final comments. I like this quote by Niels Bohr, who's a physicist, of course. Prediction is very difficult, especially about the future. And I think it kind of captures what we're trying to do. So we're trying to predict something, but we really don't know what that future is. So we're kind of trying to learn as much as we can about the patients that get their treatments, and trying to see if it helps us make a better decision for new patients that come through the care path. And the other really interesting quote is from a fellow named John Tukey, who's a statistician. The greatest value of a picture is when it forces us to notice what we never expected to see. And I think this is where the value of the big data comes in, is that we don't know what kind of trends there might be out there. And it behooves us to say, well, let's not make any assumptions. We have the ability and power to use the kinds of tools that say, let the computer tell us what kind of trends there might be in the data. I think we have that ability. That's it for my talk. I hope I didn't go over. Thank you very much for your time. I want to thank the West Coast Motorcycle Vet for their support for this. University of Victoria, of course, and we have a team. Each of those members would like to thank. Thank you very much.
When you refer to the movement of the prostate, you're you're referring to actual physical movement?
Yeah, it's pretty interesting. And to make it more complicated, the prostate motion isn't just a hard sphere, right? It's kind of like a softer walnut. So it's deformable, you can squish it. And so you get that happening as well. So sometimes we see images of these motion assessments where there's a gas bubble in the rectum that's coming out, and the prostate's actually kind of squished during that treatment.
Poor design.
Yes.
You mentioned at the start one of the long-term effects in radiation treatment is either blood in the urine or blood in the stool.
Yeah.
Is that an offshoot of something that the radiation caused, or is it a sign of something that would be more serious? Or is it to be expected?
Well, the way that I understand this is that there seems to be a relationship with the amount of radiation that you give and the chance that you can get those kinds of complications. So if you have a very large volume of the rectum that receives a high dose, then there's a pretty high chance that there could be those kinds of complications. And so that's what the data suggests. The data also suggests that if you reduce the amount of volume, that high dose that the rectum or the bladder gets, the chance of getting it is reduced.
But is that a serious implication, or just something you have to live with?
Most of the time, it's not serious. Usually they're straight, like there's different sort of categories of the side, like how bad the side effect is. So it can range from very marginal, not very troublesome, to being quite significant. But that's very rare that we would have to stop a treatment, for example, because of those complications. Yes.
How many patients have actually had the seeds implanted to monitor the motion of the prostate?
In Victoria, we've been doing it for probably about 2 years. So most patients that are getting radiation therapy for stage 1, stage 2 disease will have initial seeds inside the prostate. Not every single one of them will. Usually what happens is we're starting to see more and more patients get those seeds in that procedure. That's part of the procedure. So that's one approach. Now the other thing that I should mention is that you can use the seeds to get really accurate with positioning the tumor. But you can also use some additional technology that's on the machines now, and that's to actually acquire another colony, another CT image while the patient's on the couch. So you can actually collect a three-dimensional image of the patient and the prostate and all the other stuff, and then do another fine-tune adjustment on the treatment. And that's becoming more prevalent in our treatments today. Yeah.
You said that good data is hard to get or hard to find. Why is that?
It's because one of the things that we often encounter are, for example, some of the data that I wanted to be able to use. For example, the patients that have seeds in them from say 2 years ago, we collected a lot of information about the images of where the seeds are just before they get treatment, but we don't get the data right after they're treated. And so it's interesting information up front, but it doesn't help us figure out, how much motion occurred during the treatment. So it's okay data, but it's not really going to help us figure out how much motion is occurring during treatment. So it's just sometimes we just don't, we're not thinking that far ahead about whether we can use that information. So that's some of the challenges.
Thank you very much.
Thanks. Oh, did you have a question?
Yeah. I used to go for part of my radiation after I finished work.
then I got to a point where I couldn't do it, so I was then having the radiation in the morning. So the lining up on the machine, I used to find that in the morning, the ladies spent way more time trying to line me up. Would that be because of this growth or movement? Because in the latter part of the day, I was literally on the table, just a few adjustments and bingo, we were off to the races.
That's a multifaceted question. I think that one of the things that we try really hard to do is to be consistent in that approach and how we set patients up just before their treatment. And so some of the things that we do is we try to sort of anatomically align yourself so with these external lasers and try to get you sort of level so that you're not rotated. You're not rotating this way, you're not rotating back. And so, you know, I will admit that there can be at times some degree of inconsistency in some of the staff and how they might set things up. However, when you look at what happens during the course, just before the treatment, what we do is we're taking images of you just before you treat and making an adjustment anyway.
Yeah.
So any small little offsets that you might have on a day-to-day basis kind of just get washed out after we do that adjustment. And so that's one of the issues there, is that we're hoping that by making those small adjustments that we get rid of that.
Yeah, no, I just meant that their adjustments were way more at 10 o'clock in the morning, aren't they, than what they were at 3:30 in the afternoon.
Yeah, I can't answer that question.
I was
I
just
can talk with that.